A very good evening to everyone present today for Manthan, our webinar for the evening. And thank you for joining everyone. Next slide. So, in case you have any questions, please post your questions at any time in the chat box, and we'll bring them up for discussion at the end of the session. Next slide. So I'm Dr. Parvan Shetty, Director of Medical Affairs at Venus Medical Research Center, and I'm a DM in Clinical Pharmacology at, from KM Hospital, and I've previously worked with Pfizer, Eisai, McLeod's Pharmaceuticals Limited. I have multiple publications and conference abstract to my credit. And the next slide. So the distribution of pathogens in the Indian ICUs, as per the ICMR 2023 AMR report, shows that the various gram-negative pathogens, which includes Acinetobacter baumannii, Klebsiella pneumoniae, E. coli, and Streptococcus and Pseudomonas aeruginosa, are causing havoc, and this is a very threatening sign for our future. And that's why the antimicrobial resistance and the topic of antimicrobial resistance becomes very important for us. Next slide, please. So the topic for today is clinical insights and innovations for polymyxin-based therapies, and a brief insight by our experts on antimicrobial resistance and antimicrobial stewardship. Next slide. So I would like to introduce all our panelists and moderator for today. Firstly, our moderator, Dr. Abdul Ansari. Next slide. Dr. Abdul Ansari is Director Critical Care of Nanavati Max Superspeciality Hospital, Mumbai. He is the national and international faculty at many forums with multiple publications to his credit. He has previously worked with Lilavati Hospital, and he has recently been awarded as Inspiring Intensivist of India Award by the Director General of Army Medical Services. Next slide. Dr. Bharat Jagiasi is our panelist for today. He is the Director of Critical Care at Kokilaben Dhirubhai Ambani Hospital, Navi, Mumbai. He is the current General Secretary of ISCCM with multiple publications to his credit. He has been part of the ISCCM scientific committee in the past, and he is a national and international faculty at multiple forums. Next. Dr. Jay Kothari is the Director of Critical Care, Apollo Hospital International Limited, Ahmedabad. He has previously worked with Lilavati Hospital, Mumbai, and he has been the national and international faculty at multiple forums with multiple publications to his credit. And he is a ISCCM faculty for training young physicians. Next. Our third panelist for the day is Dr. Sharad Seth. He is the HOD of Nephrology at Kokilaben Dhirubhai Ambani Hospital, Mumbai. He is the first DM nephrology pass out from the prestigious KEM Hospital, Mumbai, and he has more than 40 years of experience in nephrology. Has earlier worked with Nanavati Hospital and has multiple national and international faculty at multiple forums, and he has multiple publications to his credit. Our fourth faculty and panelist for the day, Dr. Bhagyesh Shah, is the head critical care at Marengo CIMS Hospital, Ahmedabad. He is a national and international faculty at multiple forums with multiple publications to his credit. And he is the ISCCM faculty and ACLS instructor for training young physicians. And he is a certified infectious diseases and HIV specialist. And lastly, we have Dr. Punit Ghetiya. He is the head critical care at Bankers Heart and Multispeciality Hospital. He is the ISCCM secretary of Vadodara chapter, and he is the national faculty at multiple forums with multiple publications to his credit. I further hand on the session to Dr. Abdul Ansari to take us through the moderation for the session.
So, thank you, Dr. Shetty, for such a wonderful context setting. And I would like to, take this opportunity to, first of all, thank Venus for this wonderful initiative on the kind of not exactly the eve, but on the week of AMR awareness. As we all aware that antimicrobial resistance is actually a global challenge. And very disturbing data have been published by WHO and the Society for Research on Infectious Diseases and CDEP, disease economics and their impact dynamics. And they have shown that very soon AMR is going to be the biggest economic burden for all developed and developing countries. And the major reason is that increasing antimicrobial resistance. As in the opening slide, Dr. Parvan had very clearly shown that in our country, we are already dealing with unmet, kind of a resistance scenario, which is 70 to 90% of carbapenem resistance in super specialty areas. And even in community, a whopping 40 to 60% of resistance, which is threatening to destroy all credible antimicrobial therapy. So with this background, and telling that Venus has been for the last more than a decade been instrumental in getting those innovative molecules, especially the patented ones, which have been like a plea, if I can say, a plea towards antimicrobial resistance, and has been trying to get innovative molecules in which the two molecules will stand apart. One of them, the Ilores, and the other one, Polymyxin, which we will talk about during the course of the talk, have been instrumental in kind of providing a solution in that gap, which is because of increasing antimicrobial resistance. So I would request all the participants to actively, kind of engage themselves, take the benefit of all these senior faculties. We have right now the most senior person, Dr. Sharad Seth, who is a doyen in nephrology, and Dr. Jay Kothari, Dr. Bharat Jagiasi, Dr. Bhagyesh, and Dr. Punit, who are all senior critical care specialists here. And we can probably have an open forum discussion on few questions, and really from bench to bedside practice. I would request everyone to, rather than kind of giving a complete one-sided view, but rather a balanced opinion of what they feel in clinical practice about these challenges. So just to open up this forum, and I will request all the participants who have joined, thank you all of you for joining. There are more than 70 participants that I can see online, to just type their questions. We'll definitely take them towards the end. To just open up and warm up, I would actually request Dr. Punit to really kind of talk about this question, which is on your screen, about, please share some experiences in brief about the challenges that you face in day-to-day practice in antimicrobial resistance. And then I would request all my fellow esteemed panelists to also kind of share their opinions as briefly as they can. Over to you, Dr. Punit.
Very good evening. Very good evening to my all teachers, very senior colleagues, and to open up the forum. And I are really thankful to Venus Remedy for consider me as a panelist. And I can see one of the dream to come to interact with obviously authority with antimicrobial and antimicrobial treatment and all the very pioneer work in all across the India and world. So yes, back to question. It is very obvious when I had been there in Kokilaben in 2010-11. We usually having a very low resistance bug, but susceptibility over a period of time, we are getting the very emergence of microbial resistance in all over the gram-negative bacteria is more becoming resistant. So yes, it is a very now we are adding a very difficult in that direction. To start with a carbapenem, but we are not really sure that bug will be the sensitive or not, because multiple factors. When the patient referred is already having cover with a broad spectrum antibiotic, there is no appropriate antibiotic stewardship, and maybe multiple times they have admitted in a various place to having a exposure to antibiotic. So antibiotic resistance is very crucial in our day-to-day practice. So we are obviously fighting with that problem. And I request all other panelists to throw some light in this.
Thank you. Thank you, Dr. Punit, for opening up. Dr. Bharat, would you like to kind of add something here?
Yeah, so it's a thank you, Venus Remedy, for having me on board, and thank you, Dr. Ansari, for all the help. So to answer your question, of course, it's a big problem. I mean, there's no brainstorming over here, and the major issue is initially, as we all go with the empirical therapy, but initially in our days, as Puneet rightly said, it was very easy. You go with the meropenem, it will cover everything for you. But now CRE and beyond game is different. you need to have the causative organism and targeted therapy. It's not same beyond the CRE. So we have the limited options available. It takes time to identify an organisms which is around and how it should be treated. Uh, Otherwise, if we end up those days, the disease gets severe, so morbidity, mortality goes up, which increases the healthcare cost. And of course, it's not easy to identify. We know, okay, many of the cultures, almost 20-25% of the cultures come positive. We are too much dependent on the diagnostic therapies, and those are also really not helping us. And again, those are costly. So, identifying organisms and then the gene which is being involved is very important in this with the limited options available across.
Thank you. Thank you so much, Dr. Bharat, for putting it and closing it. Can I have a next slide, please? So, can we just change the slide? Yeah. So this was actually the consensus guideline which comes from ICONIC study, which I thought I'll just show for our all participants, which is actually Indian consensus on the management of carbapenem-resistant enterobacterials called ICONIC 2, which very clearly shows that there are major 4 consensus high quality statements about carbapenem-resistant E. coli and Klebsiella are most common causes. NDM and OXA-like resistance mechanisms are very, very important. Carbapenemase production is an important mechanism, as we all know, and NDM with PBP3 inserts, AMP-C are emerging mechanisms of resistance in CR. E. coli. And finally, NDM with OXA48 is a very common resistance mechanism. Just to kind of name up the few consensus kind of statements, this can sum up the initial question that we tried to answer. What is the current ground reality, which we started? Next slide, please. With this, I would actually ask Dr. Jay Kothari to now come in and take this question about choosing an empiric antimicrobial therapy for critically ill patients, especially who are hemodynamically unstable. So, Dr. Jay, what is your usual approach at the bedside?
So, with the huge level of antimicrobial resistance that we are seeing in and around, choosing empirical antibiotic for hemodynamically unstable patient creates a lot of challenge, or probably there is an end to the challenge, because you will have to use the polymyxin or colistin-based therapy, at least for hospital-acquired infection in our part of the hospital. But basically, you will have to see the antibiogram of the hospital to learn and understand the empirical antibiotic selection for the hemodynamically unstable patient. And most of the hospital, what we are seeing as of now, if the patient develops hospital-acquired infection, 60 to 80% of time, it would be NDM or it would be carbapenem resistance. And with that, would leave us with lesser choices, and we'll have to probably use polymyxin or colistin-based therapy for hemodynamically unstable patient. Of course, the source of infection which you suspect or which you can prove becomes the major contemplating point to decide the empirical choice of antibiotic. Gram-negative, gram-positive fungal infection, and so on and so forth would be important aspect to learn or to have a clinical judgment when you have lesser investigation available at the time of onset of sepsis or septic shock or hemodynamic instability. And the third thing is, for almost all relevant hospital-acquired infection where patient is hemodynamically unstable, we probably need to use combination antimicrobials to treat the serious infection. And if there is fungal infection suspected, then we'll have to use echinocandin as the choice of drug for such kind of patient. That's what is the 3 groups. Empirical antibiotic is challenging, but with the kind of emergence that we are seeing, it is most of the time polymyxin-based therapy.
Thank you, Dr. Jay, for such nice kind of elucidation of the thought that you have at the bedside. Dr. Bhagyesh Shah, would you like to kind of pitch in and tell what is the thought at your back of the mind?
So we both, Dr. Jay and I myself, have worked in Ahmedabad together and now in different hospitals. We share the same view, specifically as far as the question goes. The only thing is the problem where we see a hemodynamically unstable patient coming to us in a tertiary care center with a metro city. will be the time ticking. So unless we treat them as fast as possible and do the source control as far as surgical things go, we are almost seeing a mortality up ahead. And the time which we have wasted in transfer of this patient to our hospital, or the time which was wasted by the other hospital in diagnosing, sometimes pushes us to go for the costly investigations like PCR-based testing and enzyme studies and all. But ultimately, the aim is to save the patient. So the empiric choice definitely matters. And for now, we are left with one or two options as empiric choice in hemodynamically unstable patient where we are suspecting CRE. So yes, our choice is same, probably.
Thank you, Dr. Bhagyesh. Uh, would you like to pitch in, Dr. Bharat, quickly?
Yeah, so here the knowing antibiogram is very important. What is common in your ICU, because as when we suspect CRE, so of course if you know the genes of your whether it's MC or KPC or OXA48, then it's an easier job for you. Or even if you know whether club is a problem with you, or Acinetobacter is a problem with you, or Pseudomonas is a problem, then the empiric choice would of course vary in all the three scenarios. So important to know the organism which you are expecting in your hospital to be there, and then accordingly covering it.
So, thank you very much. Can we have a change of slide, please? So, thank you, everyone. I think this is a mind map which can be a very good idea for all those participants who want to carry something that look at the infection site, the most probable pathogen, the risk factor for MDR pathogens, molecular microbiology results, your clinical severity scores, and finally, what could be the best dose optimization. So, this would be something which should always go at the back of your mind wherever you are dealing with this kind of an empiric antimicrobial therapy selection in a hemodynamically unstable patient. Next slide, please. So this is actually the ICMR 2022 empiric therapy guideline, which says, as Dr. Bharat very rightly pointed out, local antimicrobiogram, which is antibiogram, which is going to be very, very important. The previous history, the risk factors of antimicrobial exposure, and obviously the organisms identified if earlier in the previous 6 months of the prior admission, and what were their antimicrobial susceptibility data. And especially for those hospitals where you have very high incidence of Acinetobacter or Strenotrophomonas or breakthrough infections, you may have to keep that also in your empiric choice of antibiotic account. Next slide, please. So with this, we will come to our third question, where I will ask Dr. Bhagyesh Shah that how do you kind of prefer de-escalating antibiotics following the treatment of sepsis? And do you have any particular factor that you consider while deciding to de-escalate once you have started this empirical therapy for that unstable patient and you are getting some kind of a response? How do you kind of actually go ahead and decide, or what timing or what factors?
So if you ask me that what is my choice while planning to de-escalate, I would say that I don't rely much on the laboratory parameters like procalcitonin and all. I see the patient clinically. If the patient's hemodynamic instability, which pushed me for the empiric antibiotic, has been resolving significantly in last 48 hours, and I have my bug, I have my enzymes, I have my resistant pattern with sensitivity report and MIC, then I may definitely wish to de-escalate. The use of procalcitonin or CRP is not consistent as far as my practice goes, because the test in my setup is quite costly. It cost almost a day of antibiotics sometimes. So a serial PCT is not possible in all patients. Sometimes they are not in that affording class. And our view is sometimes to keep them in our hospital till they stabilize. So I do de-escalate based on clinical parameters in last 48 hours. If the patient has been stable, we do de-escalate. And for the first question of your this question, do you prefer de-escalating? I would be happy and always ready to de-escalate if my patient is improving, and that gives a good that at least my patient is surviving. So that is
Thank
my
you.
answer for now.
Thank you. Can I request Dr. Sharad Seth to kind of give his feedback, especially for genitourinary infections, where source control can have dramatic effect, like putting a DJ stent or having an emphysematous pyelonephritis, where you have done some surgical debridement. Sir, what do you feel? What is your thought process about de-escalation after you feel a source control has been achieved?
Thank you, Dr. Ansari. Am I audible? Yeah.
Yes, sir.
Thanks to
Yes,
Venus
sir.
Remedies. And I fully agree with Dr. Ansari that in urogenital, the majority of these complicated UTIs as a source of sepsis requires surgical intervention, especially in diabetic cases, as you rightly said, emphysematous pyelonephritis or renal calculi or prostate enlargement, and a lot of residual urine, and also intervention and source control in urological sepsis is very important. And here we all together, we know very well that now sepsis has become a real nightmare. And once a patient goes in septic shock, is very likely to go into acute kidney injury, and that would multiply morbidity and mortality. And the unfortunate part even today is 20 years back when I was a student, the mortality was 50% plus. Even today it is same, despite having newer antibiotics. So the antibiotic stewardship, source control is of utmost importance, and probably a nephrologist always gets involved with the intensivist to prevent acute kidney injury, because having had acute kidney injury, the cost accelerates to almost double, triple, and the stay in the ICU and the hospital also becomes triple, 3 times. So I think we together should prevent acute kidney injury at any cost.
Thank you, sir. Dr. Bharat, would you like to kind of pitch in here? How would you like to, approach de-escalation or timing or factors?
So de-escalation comes on many areas though. First is, as rightly said by Dr. Bhagyesh, is patient improving. So once the patient is hemodynamically stable and we see the labs parameter getting better, this is the point where you think of de-escalating, and followed by, as when we start with the empirical therapy. So as Dr. Jay said, we'll be targeting many organisms, maybe MRSA, CRE, fungus as well. So once we have the microbiological culture ready with us, and then we stop all those empirical treatment and we go with the targeted therapy, that is again a de-escalation when we cut down the number of antibiotics and antifungals which have been used. Second is, of course, the duration of therapy. This is what we forget many of the times. Once the patient has been stabilized and we have achieved enough, I don't know what everyone else follows, so it varies from 3 days to 5 days to 7 days to 10 to 14 to 21. So we should now have those day parameters in time. And when we talk of the nephro infections, I think 3 to 5 days, once the patient is stable, then we should think of coming down or maybe stopping. And if at all we are using the procalcitonin, as we always do in our cases, so it's very good indicator when there's a fall from the peak almost by 80%, or when it's less than 0.25, we consider stopping the antibiotics.
Thank you. Thank you so much for putting it so succinctly. Can we have a change of slide now, please? So this is just to kind of sum up all what our esteemed speakers said, that initiate, evaluate, de-escalate, and that's what the whole funda of antimicrobial stewardship is. Select the antibiotic based upon your guidelines, local susceptibility, look at the patient-specific factor, and that we have discussed, and keep on evaluating, as very clearly told by Dr. Jay, as well as Dr. Bhagyesh, and even Dr. Bharat very clearly said that daily review of clinical signs, review of culture, analyze your dosing strategy and molecular diagnostics, and this is called as the optimization, kind of scale. And finally, you need to now go down to a narrowing of therapy. If your cultures are positive, reduce adverse events, consider shorter duration, which may be based upon clinical status. And although biochemical markers are now slowly coming in, especially if you have a sidality, on board, that means if you have a very highly effective antibiotic to start with, then even 5 to 7 days surviving sepsis guidelines allows. If source control, hemodynamic optimization, and organ supports have come down, you can do it. But there are some caveats. Very heavily resistant bugs. There is no clarity whether a rebound infection can come in, especially if you are using novel BL-BLI combinations, or when you are having a borderline source control, or you have a risk factor like a host which is very weak. Probably there just sticking to a 5 to 7 day hemodynamic stabilization may not be enough. You may have to extend it to minimum 2 weeks duration, especially because of the MDR status. So next slide, please. So now the important question about what hematological parameters, biomarkers, and other monitoring mechanisms you consider relevant for initiation and ending. I think Bharat has said that. I would actually request Dr. Punit to kind of put his thoughts together about this. We can quickly move on to more relevant questions ahead.
Yes, we consider to initiate an ending of the treatment with antibiotic is to as a all in toto. First, assessment of clinical assessment of the patient, biomarkers. Sometimes there is a false alarming biomarkers are there, which is very elevated in a non-infective insult to the body, and monitoring of obviously basic parameter like pulse pressure, hemodynamics, urine output, to biomarkers to clinical features. To initiate and ending of the treatment is according to all these parameters. So CRP, C-reactive protein, procalcitonin, every time not guide us, but it is just serial monitoring of all kind of biomarker has been very useful to ending of the treatment. But clinical improvement, hemodynamic stability, and patient's well-being. And obviously, first we have to consider our ICU and our antibiogram. If some MDR or nasty bacteria is there, so we have to consider the treatment prolonged time, and by the time we have to find out the source, and if possible a radical source control is very important to consider the ending of the treatment. Yeah,
Dr. Jay, I would like to hear from Pearls from you, because most of the time it is the clinician who has to decide. Every guideline talks about at the discretion of the clinician. So what would you suggest our participants to kind of focus on, Dr. Jay?
So for initiation, if we talk about few things needs to be considered, and the most red flag thing that I would like to highlight here is people starting an antibiotic or escalating an antibiotic depending upon the procalcitonin level, and we'll have to refrain from those kind of things, starting with because there is procalcitonin high, or escalating because there is procalcitonin high, without the clinical, hemodynamical, or overall judgmental part of it. So that's something which is what I'm seeing across many places. I would like to red flag those kind of things. Procalcitonin can be used for de-escalation or stopping, if at all, but not for the initiation of the treatment. And for initiation, of course, the local antibiogram and whatever parameters that we have discussed to begin the empirical antibiotic, we need to consider those kind of things. The other important thing, which is the site of infection, that all of us should be considering very heavily, whether it is pneumonia, whether it is urinary tract infection, the choice, duration, and the strategy of treating those kind of infection, whether it is brain, whether it is bed sore, whether it is just a paralytic ileus. The choice and the duration and the strategy of managing such kind of infection would differ depending upon the site of infection. And as far as ending the treatment is concerned, of course, as you rightly mentioned, that there is no consensus guidelines, and probably we'll have to treat the resistant organism with a little more number of days. And one more thing is, again, here also on ending the therapy, source control and site of infection becomes a major concern. Depending upon if there is osteomyelitis, you can't just take fever subsidence as the end of therapy. So where is the infection? If it is endocarditis, if it is brain infection, or if it is deep infection or deep-seated infection, then stopping has to be as per the guideline for that site of infection, which is what I would like to add on to the previous discussion that has happened. And for de-escalation or for ending or for changing, we should also have to monitor the side effects of the drug. Sometimes drug is going to be excellent, but then it is already creating side effects, and in that case, we'll have to change the current drug which is on board, even if it is effective. That's something 2 point I wanted to add to the previous discussion.
I think very well taken. These are the 2 points which all the participants must keep in their mind, because site of infection is the primary determinant. Because as very rightly said by Dr. Jay, endocarditis, deep-seated metastatic infections will definitely have a totally different role. Bone and joints, DAIR, debridement, removal of the implant, and kind of continuing therapies will have totally different impact. So one size doesn't fit all. And very important, one parameter that we forget is the host. If your host's immunity has not been reconstituted, then probably that defervescence may be a totally different sign. You may be actually moving on from cross, category infection, from gram positive to gram negative, or gram negative to gram positive, breakthrough infections or fungal infections, and even viral reactivation syndromes have to be kept in mind. So this is something which is actually an art of medicine rather than a very clear-cut number that you can adhere to. Next slide, please. So I would like to, just for the purpose of making everybody understand, that this is called as a personal care bundle for optimizing antimicrobial treatment. If you look at these 7 steps: obtain specimens, start antibiotics quickly, start therapy using broad spectrum antibiotics, stop therapy on day 3 if infection becomes unlikely. That's very important. Use PK/PD data to optimize your treatment. Step 6 is streamline antibiotic therapy, or use narrower spectrum if you have the report or etiological agent is identified. Switch to monotherapy, but again, not day 3. It depends upon what kind of bug you are treating. This is again 2016 data, when the impact of very highly resistant organisms was not so high. But I would say look at a personalized approach and keep looking on the other side, the rationale behind it. If you have MRSA, if you have Pseudomonas, Acinetobacter at difficult to treat site, you will not be able to follow all those steps down. So important thing to note, look at your host immunity. Number 2, look at the site of infection. And finally, the organism that you are treating with, and whether you have been able to achieve reasonable source control. Next slide, please. So this is again another therapeutic strategy that people have kind of shown, has been kind of written in the same article, where people said that if there is clinical improvement at the end of 72 hours, if your cultures are negative, you can seriously start considering about stopping antibiotic. If your cultures are positive, think about de-escalation. And if there is no clinical improvement, you need to really keep on asking yourself, what is the more diagnostic appropriate strategy? Next slide, please. In fact, what is very, very important is that at this point of time, if you look at that, this is Mokrani et al. Very clearly mentioned in the latest study, that if no potential source of infection, consider whole body CT scan or some other diagnostic modality which would be able to help you identify whether we are dealing with inflammation or a very closely located pocket of infection, or some kind of lost opportunity for debridement or missed diagnosis. Next slide, please. So with this, we are moving towards the second half, where now I will invite Dr. Sharad Seth to kind of start with this. What is your personal clinical experience about polymyxin B as compared to colistin for various types of nosocomial infections, especially the catheter-associated UTIs and genitourinary infections? And what is your preferred modality of antibiotic? Because we know that in nephro and urogenital infections, there are little limitations of polymyxin B. So over to you, sir.
I fully agree with you, Dr. Ansari, that colistin comes from the prodrug cholestyramine sodium, and it is mainly urinary excreted. So in urinary urosepsis, colistin is preferred over polymyxin B. But if there is a systemic infection, then polymyxin B is preferred over colistin. So for urosepsis only, colistin is the drug of choice as of today. Otherwise, we go for polymyxin B. As I said, we have to control acute kidney injury, and polymyxin is renal friendly, much more renal friendly than colistin. And now we have this new molecule, which is still more valimyxin. And I have my excellent experience. And in fact, valimyxin was first introduced by me at Kokilaben Hospital. It was not available. There was a fortunate that all my infectious disease specialists, the Vatsal Kothari's patient was there. So many a times it was my own patient. I was trying to include Polymyxin in Kokilaben, but I failed. But with the support of Vatsal, it could be introduced, and then there was no going back. We have been mainly harping on valimixin over the regular polymyxin because of its less nephrotoxicity, renoprotective drug.
Dr. Bharat, would you like to kind of add on to this nuance of polymyxins B and E, and are there other CD?
So we all know colistin is a prodrug, and it's being converted by the kidney. So of course it needs to be converted to be active. So when the kidneys are suboptimally functioning in the critically ill patient, it's a delayed activity what we see. So considering that point, colistin versus polymyxin B, called polymyxin is known to be little better in the bloodstream infections because it's an immediately available and it's immediately active as compared to the colistin. Now, as rightly said by, as we all know, polymyxin is not excreted or not metabolized by the renal route. So obviously, it's not a choice when it comes to the renal tract, urinary tract infection. It becomes debatable when it's a renal parenchyma infected. Should we be using it or not? So that's a debatable question. But overall, in SKD system, we don't use polymyxin B as such as compared to the colistin. And that is the reason why colistin is a nephrotoxic, because it has its own impact, and polymyxin, because it doesn't go through that mechanism, is not supposed to be nephrotoxic drug. Yes. What was another question?
No, this is fine. Perfect. That's good. Dr. Bhagyesh, would you like to kind of share your experience about colistin versus polymyxin B?
Sir, most of the patients we get in our tertiary care centers will have some or other kind of kidney injuries. So as far as it is not a typical urinary tract infection, even in unknown source, the empiric choice, definitely polymyxin B takes over colistin because of risk of AKI. Yes, if it is a suspected urinary tract infection, we do have to sway to colistin per se. Rest of the things already sir has mentioned. So we definitely agree that choice depending on the site is clear, then polymyxin takes over otherwise.
Thank you. So can we have the next slide, please? So these are a few recommendations which have come from the very kind of respected Dr. Suji, who had presented in Pharmacotherapy a major article which I would request everyone to read about expert anti-infectives in critically ill patients, where when we compared polymyxins, they talked about chalk over cheese and peas and pods, where it was shown the expert recommendation was polymyxin B is a preferred agent for routine systemic use in invasive infections. And this recommendation was based on the superior PK characteristics and decreased potential to nephrotoxicity, while colistin is the preferred polymyxin for treatment of lower urinary tract infection, as rightly said by all esteemed panelists, because the renal clearance of the prodrug CMS, colistin-methate sulfone, that then converts to the active moiety colistin, happens in the urinary tract. Next slide, please. So with this, now we move to the more important aspect about, what would be our preferred choices, as we have discussed, but a person who is suspected of HAP, VAP, who is exposed to carbapenem therapy and he's worsening, what is the current clinical kind of thought process? When do you really kind of resort to a polymyxin-based strategy? As we all know, that in the advent of novel BL-BLI combinations, unfortunately, polymyxins have taken a little backseat. So this is an honest question to all the panelists. I would want everyone to participate in this and give their opinion. What is the current role of polymyxin B or a polymyxin-based strategy in your ICU? Starting with Dr. Jay.
As initially I mentioned, I wanted to highlight that point only, that we have to compulsorily resort to polymyxin B based therapy till the culture reports are available as far as empiricity is concerned, because India has a very high incidence of NDM and also efflux pump kind of resistant mechanism, where ceftazidime-avibactam may or may not be sensitive. Only looking at the Carba-R report would also be questionable, even if it is positive, because bacteria can have other resistant mechanism. Fortunately, our hospital has a machine which can tell us about the sensitivity of ceftazidime-avibactam. So we follow the practice of polymyxin B-based strategy to begin with on an empirical base. And once the culture report is available, and if it is ceftazidime-avibactam sensitive, then yes. If it is resistant, then continue with the polymyxin B therapy.
Anybody would
That's
like
what
to
I
make
would
a
like.
comment? Dr. Punit or Dr. Bharat, Dr. Sharad, please, any welcome comments for HAP, VAP, or when the carbapenem therapy is actually obviously failing, or the novel BL-BLI therapies are not giving you the kind of clinical edge.
So as I'll come in.
Yeah, please, Dr. Bharat.
Yeah, so as in the initial choices I've spoken about, you need to know your battleground. You need to which you are playing. So if it's a pitch of Pseudomonas, it's a totally different bowling attack you need to have, and it's a pitch of Klebsiella, then it's a different bowling attack to have. So when it comes to the novel antibiotics, I mean those are, and Dr. Jay has also very kindly pointed out, those are have the different kind of mechanisms, and where the novel BL-BLI molecule will be of useful. But when it comes to Pseudomonas and Acinetobacter, the game is totally different. There, they might not be that much of useful because mechanism is totally different. And this is where we need to think about the polymyxin B or the colistin therapy in those scenarios. So knowing your antibiogram, which organism you're suspecting, is very much important. If you're suspecting Kleb, then of course you have the right choice with the novel antibiotic. But if you're suspecting something else, it's good to go ahead with the polymyxin B-based therapies.
Thank you. Next slide, please. So this, when we talk about the strategy, again from the Suji article, where nephrotic avoided and doses greater than those listed in this guideline should be avoided. They have mentioned very clearly the good doses. And in countries where both agents are available, polymyxin B becomes the preferred one, as we have already spoken about. Next slide, please. So having done that now, I would like to ask all our panelists now to share what are the specific antibiotic combination regimes which have shown promising results along with the polymyxin B if they have to use, or a colistin therapy, so that they can kind of maximize the benefit of a colistin-based strategy as well as reduce the drug-induced kidney injury. So starting with Dr. Sharad Seth, sir.
No, as I said earlier, that for UTI, we prefer colistin, but otherwise, in general, for all systemic infection, polymyxin B is of choice. And between the regular polymyxin B and valimyxin, I would prefer always valimyxin because it carries one supramolecular cationic colloid complex, which prevents polymyxin being taken up by tubulin and megalin receptors in the proximal tubule, and hence preventing the tubular injury. And this is a wonderful thing to happen because the entire game, already the patient is hemodynamically stabilized, hypotensive, and they're more vulnerable to acute kidney injury. So if you have a renoprotective similar polymyxin B from day one carrying forward, I would prefer that antibiotic.
Thank you, sir. Any other combination agent? Anybody wants to add phosphomycin? Bharat or Dr. Jay, would you like to kind of add another drug, or you would have a polymyxin alone strategy, which is not very highly recommended?
Yeah. So again, when I spoke about again, it's the same thing. So it's a type of the organism we are anticipating. So suppose if I'm anticipating Acinetobacter, maybe I'll go with the higher doses of BLIs in those cases. So to combine with it, along with maybe the minocycline, which is supposed to be the more active against those. And again, if it's a Pseudomonas, then I will go maybe with some combination of BL-BLI, where the certain drugs which are more effective against the Pseudomonas in those cases. So again, anticipating organism and then combining with therapy along with the polymyxin is very important, because as you rightly pointed out, in hemodynamically and critically ill patient, polymyxin alone is not the right choice. And this is the reason why, as per the CLSI, what we follow through, they never give it as a sensitive drug. It's always an intermediate what will get it in the report.
Dr. Bhagyesh and Dr. Punit, would you like to please make some comments?
Uh, Dr. Ansari, can I say something?
Yes, please.
No, same thing. Even if the culture shows resistance to carbapenem, if carbapenem is combined with polymyxin, it becomes effective because it's a detergent. Polymyxin creates holes wherein carbapenem can easily enter. So, I mean, we have to. Polymyxin alone is not preferred as a single therapy. Either it is combined with fosfomycin or with carbapenem. Even if the picture shows carbapenem resistance, clinically it is still effective. I mean,
Thank you, sir. Thank you. Thank you. Thank you for making that point. Can we have the next slide, please?
I would like to
Yes,
add
sir.
here.
Yes, Dr. Jay, please.
So for combination therapy, we have to understand whether it is empirical and whether we have culture proof or not. So for empirical, depending upon the antibiotic and the site of infection, various combination have to. Once we have the culture report available, then we know the bacteria, if it is Acinetobacter, if it is Pseudomonas, and if it is CRE. So depending upon these three group, with the choice of the combination agent would probably slightly differ. So for Acinetobacter, you have tigecycline, minocycline, and sulbactam. Depending upon the sensitivity report that you already have, and if you need to use tigecycline or minocycline, the current recommendations are to use higher dose of such kind of drugs. For sulbactam, sensitivity is not easily available, but nowadays the E-strip of sulbactam is available, and one should use that E-strip to define whether sulbactam can be added as a combination therapy against the Acinetobacter or not. For Pseudomonas, of course, you have very limited choice. Whenever you want to add or whenever you want to use carbapenem as the combination therapy, then the MIC level of meropenem has to be learned from the microbiological report. If the MIC is less than 8, then you can use high dose meropenem with the infusion. But the MIC is more than 32, 64, and so on and so forth, then using meropenem may not be very, very great. Between imipenem and meropenem has shown a little better effect or outcome with the polymyxin-based therapy. And fosfomycin can be used not as the synergistic, but as the additive drug if it is sensitive for CRE or Pseudomonas infection in some manner. There were some reports of using rifampicin at some point of time, which is not a very greatly encouraged nowadays in our Indian scenario in view of the tuberculosis and in view of the. But the major question is whether the other drug which you are going to add would create synergy, or it's going to be just an additive drug, or just going to be protect the cholesterol resistance. That also needs to be looked into when we prescribe the second drug.
Thank you, Dr. Jay. That was very.
Poly along with the fosfomycin, just a point which has been missed in CLEB is supposed to be working as a synergy.
Correct.
Yeah.
Next slide, please. So this is exactly what we were talking about, monotherapy or combination therapy. So for invasive infections due to CRE, poly-B should be used in combination. We spoke about second agent should be depending upon the displayed MICs. Preference should be based to a should be based upon the lowest MIC possible. Next slide, please. And now talking about the Polymyxin, Dr. Sharad has already explained about the vast experience that he has with Polymyxin. And I would like to now ask, Dr. Bharat to start with what does he feel about the reduction of nephrotoxic potential of polymyxin B with the novel combination or the colloidal preparation of polymyxin B called Polymyxin. Any thoughts from all the panelists, please?
So Polymyxin, of course, as we know, is a novel polymyxin derivative and potentially reduce nephrotoxicity because of the nano mechanism what they've been using. It's supposed to be not really hampering the kidney, and it has the enhanced antimicrobial activity too, along with being the nephroprotective. So this is very important because this could address the traditional mechanisms what you're worried about, the polymyxins being B or E being nephrotoxic, and of course a better safety profile and the better long-term use, as these therapies are to be given over a longer duration, and so we can use it for the longer period of time and enhance microbial activity as well. So when it comes to the personal use, I wouldn't say, as Dr. Sharad said, has been used, but I have used this drug quite a few times, not really a very big number, but as of now, of course, it's not nephrotoxic for sure. But when I have to compare with the polymyxin, I'm still about to use more than before I comment on that. I would like to use it more before I.
So I think we are heading towards the last 10 minutes of our slot. So here, if you want to take some questions from the audience, it will be great, or any of the esteemed faculty member would like to make a comment. But just next slide, please. Can we have a show of next slide? So this is exactly what Dr. Sharad Seth was trying to point out, that the conventionally the polymyxin, which is into the tubular lumen, is actually kind of picked up by the tubular cells, and megalin is one of the ways in which it allows polymyxin to get accumulated, drug accumulation in the tubular cell, and causes the nephrotoxicity. Next slide, please. And this is how the known AKI is actually kind of seen. And when we talk polymyxin, next slide, please. Can we show the slide on megalin mediated reduction of the accumulation? Yeah. Polymyxin kind of reabsorption, tubular reabsorption actually can come down. And essentially, that is probably at the heart of reducing this renal cell uptake and reduction of the nephrotoxicity, which can significantly be brought down from 13% to as low as single digit, which is a significant technical advantage. So with this, I would like to thank all the panelists and ask Dr. Shetty to please kind of take away any kind of questions from the audience or anything that we didn't cover. Please, over to you.
So currently, there are no questions in the chat box. The chat box is still empty. So we do not have any questions from the audience as such. So I request my colleague, Mr. Rajiv Handa, to address the faculty with the vote of thanks. Mr. Handa?
Okay, thank you, Dr. Shetty. Yeah, I think we have today with us all the top critical care experts of India and international faculty for addressing this wonderful webinar today. Great learning to all of us. So on behalf of my team and everyone present, I extend my deepest gratitude to Dr. Abdul Ansari for his invaluable support and guidance to us. Your vast experience in critical care field has not only enriched our understanding, but has also helped us in strengthening our presence in both India and, of course, international markets also. So we are truly privileged to have benefited from your knowledge and mentorship, sir. Thank you very much for being here today and mentoring this wonderful show today. My heartfelt thanks to all our esteemed panelists, especially Dr. Bharat Jagiasi, who has spared his valuable time today. Dr. Jay Kothari, your willingness to share your expertise and insights has been instrumental in shaping our strategies and decisions for better treatment outcomes. Thank you very much, sir, for sparing your time, sir. And I thank on behalf of everyone present here to Dr. Sharad Seth especially for sharing his immense knowledge drawn from his rich 40 years of experience on the complex yet critical topic of drug-induced kidney toxicity. Your ability to explain intricate medical concepts with such an simplicity and clarity has truly enhanced our understanding, sir. Thank you very much for being here, sir. Sincere thanks to Dr. Bhagyesh Shah and Dr. Punit Ghetiya, who dedicated to imparting knowledge for the betterment of clinical practice, inspiring us, and we are deeply grateful for their valuable insights. Thank you very much, Dr. Bhagyesh and Dr. Punit, sir. And thanks a lot to my friend Dr. Parvan, who has really the head medical affairs, for coordinating with all our panelists today and sharing the company's perspective by providing us the safer option of polymyxin B as valimyxin. My special thanks to all the participants for their invaluable contributions today, and all the attendees from across India for sparing their time in making our Manthan successful today. So thank you very much, all the panelists and our moderator. And a very, very special thanks to Mr. Anil Singh and his team members for organizing the Manthan program. Their hard work and dedication made this event a great success. So as we conclude, let us carry forward the insights.
There was one question about the role of
Please.
metro and along with meropenem. Probably it just deserves one comment that except for a serious intra-abdominal infection, probably there is no indication of adding a separate anaerobic cover in the form of metronidazole. Very rare indications would be there where bacteroids and other polymicrobial anaerobic infections are there, or difficult to reach site where a metronidazole can be added. Otherwise, I think meropenem should be good enough to take care of that. And
meropenem is also effective against E. histolytica, Giardia.
Yes.
So when those are the combinations, meropenem shouldn't be considered. And also in the C. difficile, metro is a drug of choice as compared to the meropenem. And one anaerobic, that is Bactris fragilis, is known to produce carbapenems. So
Correct.
this is where metro gel is to be considered.
Thank you. Thank you. I think we are all done here.
Thank you, Dr. Ansari.
Thank you, Dr. Ansari and all the panelists. Thanks a lot for
Thank you, everyone.
sparing their valuable time.
Dr. Abdul for having and
thank you.
Thank you very much.
Thank you.
Thank you, sir. Thanks a lot.
Thank you, everyone.